Welcome everyone. Today we're diving into a topic that sits at the heart of nursing education, how we teach, why it matters, and how theory can guide meaningful learning experiences. As future nurse educators, you'll be tasked not only with conveying information, but with creating learning environments that engage, empower, and transform your students. That starts with understanding both educational theory and nursing theory and how to bring them together in practical, impactful ways. This will be a hands-on discussion-driven lecture, so I encourage you to think both like an educator and a learner as we move through each part. My name is Jennifer Wilson, and this is for my 663 Clinical Academic Preceptorship. Before we move into teaching strategies, let's just revisit our preparation for this lecture. This topic was discussed in Module Week 6, that's Mid-Range Nursing Theories, and it was reviewed in a pre-class quiz available on Google Forms. The link is inside the slide for your reference. Middle-range nursing theories are more specific than grand theories and are easier to apply directly to clinical practice and teaching. They're built on observable phenomena and often focus on particular patient experiences, things like pain, comfort, stress, or adaptation. What makes them especially valuable, especially in nursing education, is that they bridge theory and practice. They take abstract ideas and make it easier for students to grasp. They are also flexible enough to be integrated into case studies, discussions, or even simulation. And they offer a framework for decision-making, communication, and holistic care planning. So let's take a look at where we're going today. These are our learning objectives, though what you'll be able to do by the end of this session. First, you'll be able to describe the key principles of constructivist learning theory and explain why it's especially relevant in nursing education. We'll check through this through a short quiz, but also don't worry, we'll be discussing examples throughout this lecture. I think many of you have used constructivist strategies in your clinical teaching or as a student, likely without even realizing it. Next, you'll be able to differentiate between at least 3 interactive strategies like case studies, team-based learning, concept mapping, and reflective questioning by working together on quick comparison activities. These are tools you'll want in your future educator toolbox. Next, we'll apply these strategies to a middle-range theory, specifically Kolkhobra's theory of comfort. Together, we'll design a short learning activity using the method we review. We'll then analyze the alignment between a theory and a teaching strategy through a quick reflection, drawing from your personal experience. This is important. It's not just about using a theory, it's about using it well and applying it to your life and your practice. And by the end of today, you'll create your own mini lesson plan outline, which incorporates one of the teaching methods we reviewed. This is your chance to put theory into action and walk away with something ready to use in your own educator journey. At the most basic level, you'll be able to state the purpose of incorporating nursing theory into instructional design. This gives us the why behind today's work. It isn't just academic, theory at least. It's what shapes the way we care, the way we teach, and the way we think. You're not just learning about theory, you're learning how to teach it, and most importantly, how to make it meaningful for your future students. Incorporating nursing theory into instructional design serves both pedagogical and professional development purposes. Here are 2 key reasons why it's essential. 1, theory provides a conceptual framework for teaching content. Nursing theories offered a structured way to organize and deliver content by grounding it in established concepts and relationships. When instructional design is theory-informed, it ensures that learning activities and objectives are purposeful, cohesive, and aligned with the discipline's core values. For instance, using Kolkhobra's theory of comfort to frame a learning module encourages educators to integrate holistic, patient-centered thinking into clinical scenarios, which then helps the students see beyond a task-based care. 2, it promotes critical thinking and professional identity in students. When students learn within a theoretical framework, they are encouraged to think beyond procedures and protocols. It fosters deeper reflection on why they practice a certain way and how nursing knowledge is developed. This connection to theory supports the development of professional nursing identity, and it encourages evidence-informed decision-making. It also helps students see theory not as abstract, something they can't touch, but as a living guide for ethical and compassionate care. And finally, I know you're going to be surprised, but teaching nursing theories to novice nurses is challenging due to the abstract nature. The gap between taught theories and their application in clinical practice is well documented in scholarly literature, with a meta-analysis showing minimal use of nursing theories guiding care. So by a show of hands, how many of you actually apply nursing theory to practice routinely? Maybe we can change that. We'll take a moment now to review what is constructivism. Constructivism is a student-centered learning theory, and it emphasizes how individuals actively construct knowledge by building upon their prior experiences, beliefs, and understanding. Rather than passively receiving information, learners engage in meaningful activities that allow them to explore, reflect, and make sense of new concepts in a personal and relevant way. In nursing education, this means that learning is not just about memorizing rote facts or procedures. It's actually about helping students make connections between theory, experience, and practice. So let's look at some of the core tenets of constructivist theory. Learning is active, not passive, so students must do more than just listen, right? They need to discuss, apply, and reflect. Second, knowledge is constructed. It's not transmitted. The educator acts as a guide or a facilitator rather than a lecturer. Learning is contextual. New information is best understood if connected to real-life situations. Social interaction enhances learning. Collaboration, dialogue, and peer feedback are essential. Assessment should be authentic. This includes real-world tasks that reflect true understanding. These principles naturally lead us to several instructional strategies that are effective in a constructivist classroom, many of which we'll use to teach middle range theory. So some key strategies include case studies, team-based learning, concept mapping, reflective questioning, and interactive lectures. These strategies not only help students engage with the theory, but also allow them to develop critical thinking and professional judgment, skills that are essential to their development as future nurses and nurse educators. By grounding our instruction in constructivist principles, we move away from rote memorization and toward deep, meaningful learning that supports both theoretical knowledge and practical application. So we're going to take a closer look at 6 interactive teaching strategies that are particularly effective for introducing and applying middle-range nursing theories, like Kolkaba's theory of comfort. These are case studies, team-based learning, concept mapping, reflective questioning, gamification, and simulation learning. Many of you have already experienced these activities during your educational experience. So please take 5 minutes, look at the chart, and try to fill in the blank areas using your own words or the resources you have available at your desk. Okay, now that we've had a little time to fill in the table, we'll discuss our results. First, we have case studies. These are realistic clinical scenarios that require students to apply theory to practice. Case studies are especially useful for developing clinical judgment and bridging the gap between abstract concepts and real-world care. For example, students might be asked to review a palliative care case and then identify comfort interventions using Kolkaba's 4 domains. While this method is highly engaging and context-rich, it does require a lot of careful preparation and also debriefing to be effective. Next is team-based learning, or TBL. This is a collaborative strategy where students first work individually and then as a team to solve application-based problems. It encourages accountability, discussion, and critical thinking. When applied to nursing theory, students might collaborate to create comfort plans for different types of patients. TBL is structured and effective for deep learning, though it does require upfront planning and student orientation. Concept mapping is our third method. This tool allows students to visually organize theoretical concepts and see how they relate to each other and to practice. It's really excellent for helping students clarify abstract theories and build conceptual understanding. Finally, reflective questioning. This technique invites students to think deeply about their own experiences and connect them to theoretical frameworks. It supports self-awareness, and it also encourages integration of learning. A reflective prompt could be, think of a time you provided comfort to a patient. What domain were you addressing and why? This approach is simple and adaptable. Together, these strategies allow students to engage with theory actively rather than passively absorbing content. They also support various learning styles, foster critical thinking, and promote meaningful connections. This brings us to discussion question 1, which asks, how can constructivist teaching strategies, such as case studies or concept mapping, bridge the gap between abstract nursing theory and clinical practice for BSN and MSN students? So if you're watching this video, go ahead and pause it, take a moment to consider, and then start again. So to consider, constructivist teaching strategies offer students a way to internalize abstract concepts and then actively engage with them in a relevant way. Case studies, for instance, can situate theoretical knowledge within a realistic patient care scenario, and this allows them to not only recall and apply theoretical concepts, but also to see their practical relevance in clinical decision-making. So for example, when using Kolkabra's theory of comfort in a case study, students can identify and implement comfort interventions based on the physical, psychospiritual, sociocultural, and environmental domains. Concept mapping is another strategy which further reinforces theory to practice translation. It helps students to visualize the interconnectedness and interconnections between nursing theories and real-world patient outcomes. By mapping Kolkabra's domains to patient needs, nursing interventions, and expected comfort outcomes, students actually construct a deeper understanding of how theory guides comprehensive patient-centered care. So all of these strategies align with constructivist principles by making students the co-creators of their knowledge. It requires them to draw on their prior experiences, collaborate with their peers, and also just to reflect critically. And this active engagement is encouraging, and it shifts from this passive reception to actual meaningful integration of theoretical content. And this ultimately prepares students for more theory-informed practice, something they can actually apply at the bedside. Let's take a closer look at Catherine Kolkabra's theory of comfort. So why this theory? I think it's because it's easy to apply to all levels of nursing, even novice nursing students, because it's concrete and it's very straightforward. I teach nursing for ADN programs in the first semester. And do you remember what your first semester in nursing school was like? Students are so intimidated of the environment, of the noises, all the equipment, the people walking by. Their hands and voices shake, and for some students, those nerves are so intense, I've been concerned they might pass out on their patient's lap while taking a blood pressure. So during a discussion with one of these overwhelmed students, she told me, I just don't feel ready. I feel like I'm out of place in the patient's room. I feel like an intruder. I'm not really sure how I can help. And it dawned on me, Kolkaba, because providing comfort doesn't require advanced skill. You don't have to be an expert like Brenner. The only requirements are compassion, a willingness to learn, and a desire to build a relationship with your patient. Kolkaba herself states that her motivation is nurses want to provide comfort care. I mean, it's the reason that we chose nursing. I think that statement is true for many of us. Here we're looking at the conceptual framework of Kolkaba's theory of comfort, and as you'll notice, it visually functions like a concept map. So that's a helpful connection to make, especially as we discuss concept mapping as a teaching tool. So walking through the framework step by step, the process begins when the nurse or healthcare team identifies the comfort needs of a patient, and often their family members as well. These needs can be physical, psychospiritual, sociocultural, or environmental. Once those needs are assessed, the nurse then plans and implements interventions designed specifically to address them. But there's a key piece here. Nurses must consider what Kolkaba calls intervening variables. These are factors that can't be changed by the nurse, but still influence the patient's comfort and outcomes. For example, a patient's prognosis can't be changed, their financial constraints, their level of support that they have at home. All these variables shape how interventions are selected and how effective they might be. When interventions are delivered effectively and compassionately, the outcome is enhanced comfort, which we all want. And enhanced comfort isn't the end of the story. It also leads to something Kolkaba called health-seeking behaviors. She defines health-seeking behaviors in 3 ways. Internal behaviors are changes on the cellular or physiological level, like an improved immune response or healing time. External behaviors are things the patient does in their external environment, such as engaging in self-care practices or seeking follow-up. And finally, a peaceful death is a third option where enhanced comfort helps patients and families experience dignity and peace at the end of life. But this framework goes even further. When patients experience comfort, engage in health-seeking behaviors, they report greater satisfaction overall with their care. And that satisfaction feeds back into the healthcare institution, which then receives recognition and support from the public. This is a positive cycle that reinforces the institution's commitment to evidence-based, patient-centered policies and practices, helping the system not just survive, but to thrive. So as you can see, Kolkaba's theory goes beyond individual comfort. It connects to system-wide outcomes. It's a great example of a middle-range theory that links personal, clinical, and institutional levels of care. The next slide is titled Comfort, the First Dimension. And we're looking at laying the foundation of Kolkaba's theory by focusing on its central concept, comfort itself. So she defines comfort as having 3 interrelated states: relief, ease, and transcendence. We'll break these down even further. Relief is a state achieved when a specific comfort need is met. For example, if you receive pain medication to reduce physical suffering. Ease refers to a state of calm or contentment. So this could be emotional or environmental, such as reducing anxiety before a procedure. Transcendence, then, is the most complex. It's the ability to rise above discomfort, often through inner strength, meaning, or even spiritual connection. Like a patient when they're facing terminal illness, but they still have peace, composure, and resilience. Together, these 3 states show that comfort is more than just physical. It's multidimensional and holistic, encompassing the full human experience. Interestingly, the origin of the word comfort comes from a Latin word confortar, which means to strengthen greatly. This etymology is deeply meaningful in the context of nursing. It implies that comfort isn't just passive, right? It's empowering. When we provide comfort, we're not just soothing somebody, but we're actually strengthening them to face their own health journey independently. And this is one of the reasons Kolkhabra's theory resonates so well in nursing. It recognized that comfort is not just a soft outcome, but it's actually a powerful one that can enhance healing, promote dignity, and support patients through vulnerability and complexity. Now that we've defined what comfort is, relief, ease, and transcendence, let's explore where comfort occurs. And this brings us to the second dimension of Kolkhabra's theory, the context in which comfort is experienced. So Kolkhabra identified 4 key contexts based on nursing literature about holism. The idea that care must address the whole person and not just symptoms. So number 1 is physical context, and this is the most familiar to most of us. It refers to bodily sensations and homeostatic mechanisms. So we think of things like pain, nausea, fatigue, or even temperature regulation. Comfort interventions here might include pain management, oxygen therapy, or repositioning for relief. So the second is psycho-spiritual context, and this involves the patient's internal awareness of self. It includes self-esteem, body image, meaning in life, spiritual beliefs, and even connection to a higher power. Supporting a patient's spirituality or helping them find meaning in a difficult diagnosis would fall into this category. The third is the environmental context, and this one I think is often overlooked, but so important. It refers to the external surroundings, light, noise, temperature, color, odors, and even the design of a room. For example, reducing harsh lighting in a hospital room or playing calming music can enhance comfort in this domain. And lastly is socio-cultural context, and this includes a patient's relationships, cultural background, economic resources, and access to care. It encompasses family roles, their traditions, religious practices, and even language barriers. So a culturally sensitive teaching session or arranging a family meeting can really address these socio-cultural comfort measures. What's key here is that these 4 contexts are interactive, right? Comfort in one area can influence the others. For example, improving a patient's environmental comfort may also reduce psychospiritual distress. So when we design interventions using Kolkhabra's framework, we're challenged to consider the full human experience: body, mind, spirit, environment, and relationships. That's what makes this theory not only holistic, but deeply relevant for modern nursing practice and education. On this slide is the most structured components of Kolkhabra's theory of comfort. It's what she calls the taxonomic structure, or TS. And this framework is created by juxtaposing the 2 core dimensions we just discussed of her theory. So the 3 states of comfort, relief, ease, and transcendence will be the columns on the top, and the 4 holistic contexts of experience, including physical, psychospiritual, environmental, and sociocultural, would be the rows. When you place these 2 dimensions on a 2-dimensional grid, you get 12 unique facets of comfort. Each cell in this grid represents a specific type of comfort, such as physical relief, psychospiritual transcendence, or environmental ease. Kolkhabra designed this structure to help nurses assess and plan interventions more precisely. Rather than just using vague or general comfort goals, the TS allows us to identify exactly where comfort is needed and in what way. So to measure this comfort in a standardized way, Kolkhabra also developed a general comfort questionnaire, which she called a GCQ, and it's based on the TS framework. So the GCQ uses a 6-point Likert-like scale, and it quantifies a patient's level of comfort. So patients would rate their agreement with specific statements, and the resulting scores provide insight into how much comfort they are experiencing. This is valuable because it gives us a baseline of their comfort level, and then after the intervention, we'd be able to reassess how that changed. So higher scores would indicate higher comfort, and once again, it allows for individual care evaluation and research-based measurements of comfort interventions, which bridges theory, practice, and evidence-based assessment. This brings us to discussion question 2, which states, Kolkhobra's theory of comfort emphasizes holistic care and patient-centered outcomes. How might you design a classroom learning activity that reflects these core principles, both in content and in how students experience their learning process? So if you're at home right now watching this video, go ahead and pause it for a moment and consider the question. And the first part of this question addresses learning activities. And there are so many different learning strategies that reflect the core principles of Kolkhobra's theory. On the following slides, we'll be walking through them together and building learning activities. But the second part of this question that I want to dive into deeper addresses the classroom design. To ensure the learning environment itself is congruent with the theory's principles, the educator could incorporate elements that promote learner comfort. So how do we do this? By establishing psychological safety in the classroom, we can offer flexibility in how students engage with the material. Example, we can offer verbal discussions or written reflections. And we can also value the diverse cultural perspectives that arise during discussions. This dual focus, teaching theory through both content and experience, allows a student to feel what it means to learn in a way that's truly aligned with comfort-centered care. So they're more likely to carry forward not only the knowledge of Kolkhobra's theory, but also its ethos into their future practice and teaching. It's the essence of meaningful learning. Okay, so let's take a closer look at how we can bring Kolkhobra's theory of comfort to life in the classroom. It's not just a concept, but an active learning experience that's grounded in clinical relevance. So we'll walk through each of the different learning strategies we've discussed by employing a case study from an article written by Kolkhobra titled Comfort Theory and its Application to Pediatric Nursing. In this article, nurses focus on creating a plan of care with the following goals. One, that the care be individualized, holistic, and proactive, and also child-family participation included. So the TS structure was utilized to analyze the patient, whose name is Ava, and formulate comforting interventions. Here's the case. Ava is a 12-year-old pediatric patient, a girl, female, presenting to the ED with nausea, vomiting, and abdominal pain. She now requires a peripheral IV for fluids, antiemetics, and pain management. But before initiating the procedure, the nurse makes a critical choice, not to act immediately, but to pause and assess Ava's comfort holistically using the modified GCQ tailored for pediatric use. This moment reflects the heart of Kolkhobra's theory. Care that doesn't just treat symptoms, right, but honors the whole person, their emotional, spiritual, physical, and social context. So how do we translate this into a meaningful learning activity? As educators, we could assign Kolkhobra's article as a pre-class rating, and then we can choose to do team-based learning, TBL strategies during class. We would randomly assign students into small groups, and random assignment promotes diversity of thought and interaction, just as TBL suggests. We could ask each group to complete the TS for Ava's case and identify what comfort needs are present, in what context, and which interventions would be most appropriate. Then we could have each student in the group take on a specific role. One could present physical comfort needs, another could explain sociocultural aspects, and another could focus on psychospiritual, and so on. So finally, each group could present their analysis to the class, which fosters discussion, peer learning, and also reflection. This is a really rich constructivist activity. It encourages students to engage with the material, analyze real-world application, and then collaboratively build knowledge in a way that mirrors clinical practice. So by the end, students aren't just learning Kolkhobra's theory, they're using it critically, creatively, and even compassionately. So after students present their findings, it's important to compare it to what was found in the actual article. And after the nurses in the article completed their assessment, they used the TS and organized Ava's comfort needs. They found physically that Ava is experiencing nausea and abdominal pain. Psychospiritually, she's feeling anxious, likely due to the fear of an IV procedure and an unfamiliar environment. In the emergency room, it's pretty loud, noisy, and chaotic. Socioculturally, the nurse recognizes that reassurance is needed, not just for Ava, but perhaps for her entire family, given cultural norms and age-related communication. Environmentally, we might infer that factors like the noise, lighting, and ED simulation could also be influencing her comfort. So from this structured assessment, the nurse can now design targeted, evidence-informed interventions. This could be the use of distraction techniques when starting the IV, child-friendly language, comfort positioning, and involving family support. What this case beautifully illustrates is that comfort is not incidental, right? It's very intentional, and using the TS in a theory-based tool like the GCQ ensures that the nurse addresses not only medical needs, but emotional, cultural, and developmental dimensions of pediatric care. This approach transforms a routine procedure into a therapeutic opportunity. And it's a great example of how theory guides compassionate, holistic, and age-appropriate nursing practice. Now that we've identified the comfort interventions that we would like to implement, it would be a great time to use hands-on simulation. So in our specific scenario, Eva is facing a stressful procedure with a peripheral IV insertion for hydration, antiemetics, and pain control. And rather than treating this as a purely technical task, we could use Cole-Cabra's comfort theory as our foundation for designing a holistic care simulation. Each comfort intervention could be woven into simulation activities that reinforce both clinical skills and compassionate care. So we could start by simulating the procedure in a pediatric treatment room that's designed with warm lighting, child-friendly decor, reduced noise. And this creates a calming space for the learner and patient alike. We could also use a standardized patient actor or a scripted family member to practice providing age-appropriate explanations with the support of a translator or a child life specialist. This also reinforces cultural sensitivity and communication skills. Students can then practice drawing up let gel, applying it correctly, and prepping distraction tools like a tablet or iPad or music. They can also demonstrate proper positioning to the parents or use a mannequin or a partner to show the child how to be held in a comforting position. Often this is in the arms or lap of their caregiver. Simulation stations can then include IV insertion techniques on pediatric arms or task trainers, drawing and labeling antiemetics, priming IV tubing for the fluid bolus, and using verbal reassurance to support the child throughout the procedure. So role-playing how to maintain a calm and positive presence and offering reassurance using therapeutic communication throughout the simulation, even subtle tone, facial expression, and body language really matters, and practicing it is the only way to get better. So the key here is that simulation isn't just for technical skills, it's actually a really powerful opportunity to embody the theory. So through the exercise, students act out the nursing process. They apply Cole-Cabra's theory in a meaningful way. They deepen their understanding of holistic, family-centered pediatric care. And by the end, students not only know interventions, they've lived them, they reflected on them, and they've seen how theory can elevate practice. In this next activity, we'll explore another powerful teaching strategy, and that's concept mapping. And it's a way for students to visually organize and apply Cole-Cabra's 4 holistic contexts of comfort to our pediatric case. So for this assignment, students will use a digital tool. You could use something like Poplet to create a comfort-centered concept map based on Ava's scenario. Using Poplet allows students to visually organize their thinking, make connections between theory and care, and present their reasoning in a clear and structured way. It also really fosters creativity and engagement, especially when you're working in groups. You can choose to have students work individually or in teams, and then share their concept maps with the class as part of a reflective discussion. This, again, not only reinforces learning, but it builds communication and collaboration skills as well. So I've listed the link to the Poplet application on this slide. Students from APU can create a free account using their Canva login. In this final activity, we're inviting students to pause and look inward, connecting the principles of comfort theory to their own lived experiences as nurses. This reflective journaling assignment asks each student to recall a time in their clinical practice when they provided holistic, comforting care. A moment where they were fully present, they were attuned to their patient's whole experience, and able to foster calm and trust. Students will describe the situation and identify which comfort context they addressed. Was it physical, pain, emotional anxiety, environmental stress, or perhaps a cultural or spiritual concern? What interventions did they use? How did the patient respond? And most importantly, what did this moment teach them about the power of intentional, compassionate nursing? This exercise also aligns with constructivist learning. It helps students build meaning from their own clinical experiences and make deep connections between theory and practice. It's also a chance for students to rediscover the impact they can make, not just through tasks and treatments, but through presence, understanding, and comfort, that art of nursing. These reflections can be kept private, they can be shared in small groups, or used to spark larger class discussions on emotional and relational aspects of nursing. As we close, I want to highlight that this lecture itself has been an example of what we're discussing. It's an interactive, constructivist-based learning experience. So rather than simply presenting facts about middle range theory or Cole-Cabra's framework, we walked through a case. We applied that theory in real time. We explored teaching strategies like concept mapping, reflective journaling, simulation, team-based learning, all of which are designed to actively engage learners in building their own understanding. This is what makes a lecture interactive. An interactive lecture doesn't rely on passive note-taking. It incorporates real-world application through case studies, collaborative problem solving, visual, hands-on tools like Poplet or simulation, reflection to deepen meaning, and the freedom to connect theory to personal practice. As future nurse educators, you'll be designing lessons that not only transfer knowledge, but ignite curiosity, critical thinking, and emotional connection. So the next time you step into the classroom, virtual or in person, remember that theory doesn't have to feel abstract. With intention and creativity, you can bring it to life just like we did today. You will find the QR code here linking to the post-lecture quiz on constructivism and middle-range nursing theories. This week, you will also design a mini teaching lesson using a constructivist learning strategy and a middle-range theory of your choice. You can submit these teaching plans to the discussion board associated with this module. One of my favorite sayings reads, "People will forget what you said, people will forget what you did, but they will always remember how you made them feel." When reflecting on Catherine Cole-Cabra's theory of comfort, I'm reminded how far a warm smile, a handshake, a reassuring touch, those graham crackers, and definitely a warm blanket can influence our patient's day and their recovery. Thanks so much for listening and following along. Take care, everyone.